Well, this is not the way I had planned on us doing our lectures this year, but I hope that y'all will realize that I'm going to be in good shape because I've got enough Snickers to get me through. And thanks to y'all, I'll be able to sustain all of this COVID issue and be able to live through it. But I did want you to know that I do not enjoy teaching this way because I can't look you in the face and see your facial expressions and understand where you're understanding the material or whether you get it or not, if I need to present it in a different way to get you to understand it. So it does make it a little difficult. So I have to rely on you with some feedback on things in which you don't understand or that you need some clarity on. So don't hesitate to email me if you've got any questions. Let me also emphasize to you that in this section on the respiratory system, especially 38 and 39, those chapters, you really need to pay close attention to the slides, not so much the book. Guyton goes about this from a pure physiological perspective, and we need to look at all of this from a pure medical perspective in relationship to the respiratory system and how that plays into your profession, and especially from forced or ventilation and anesthesia machines and so forth. So we want to look at it from that type of a standpoint. So what I've done is I've taken these slides and put these slides together from a group of different books from anesthesia, some from different physiology books to help bring some clarity to this in a more medical approach. So just look at it from that perspective. So focus on the slides. If you don't understand something, I would encourage you then to go to YouTube, Ninja Nerd, Amanda is good, yet they don't do a lot of the medical applications there, but you'll be able to understand the material, I think, pretty well from what I'm explaining to you. Also, I have a video that I will drop into you that, as you see in our next section in chapters 40, 41, where we're talking about gas transfer and so forth, that I think will help clarify a big part of those two chapters for you, and I'll put that in there as well. Okay, so let's go ahead and get started. We're going to look at pulmonary circulation and pulmonary edema and pleural fluids today. Okay, so let's go ahead and get started on that lecture. Okay, now that I've finished my Snickers, we can move on with the lecture. And when we're looking at pulmonary circulation and perfusion, we have to realize that pulmonary circulation, of course, is a completed circuit with that of systemic circulation. And the whole cardiac input, or that output, is going to be circulated through the system each time. And that these pulmonary vessels have to be very compliant. In other words, they have to be able to expand a lot. Remember, anytime we're talking about compliance, we're talking about distendability in essence, especially related to the lungs. And so we have to have a lot of ability in the pulmonary side of compliance to accommodate stroke volume, because it is going to vary. Remember, if I'm laying down or standing up, or if I'm moving, I'm exercising, my cardiac output is going to vary, and also the amount of return that I'm going to have from my pulmonary side, the deoxygenated side, is going to vary. And so I have to have a lot of compliance within my lung field to do that. Also, if I have a situation where I have a backlog of blood from my left side, it's going to, if I have some reason in which I have some pathology, something from my left ventricle, my mitral valves, or my left atrium, anything there that would cause the blood to back up, then I have to have the ability to have some a lot of compliance from the pulmonary side to accommodate that as it changes. Okay, so it's realized that the pulmonary vessels are very compliant to enable us to do that. And the whole purpose of all of this is to bring blood back into contact with the alveoli. So if we look at this from the chart, and we see the fact that if we look at inspired air as it comes in, it's going to be roughly 159 millimeters of mercury of oxygen. And remember, we're talking about millimeters of mercury, or a standard of pressure. It's a measurement. And when we talk about partial pressures, which what P represents in all of these numbers you're going to be looking at, is partial pressure. Each element exerts some pressure against forces, either against other elements or against the walls of the vessel. It's going to exert a force against it. It's going to create a pressure against it. So the more of them I have, the more pressure it would exert. So the more elements I have in there, the greater the partial pressure of it. So if I look at the partial pressure of anything and I see that the number is high, it tells me there's more of them. That's simply all that means. So if I look at the PO2, the partial pressure of oxygen in the atmosphere is 159 millimeters of mercury, and the partial pressure of CO2 is only 0.3 of a millimeter of mercury. Okay, now once I breathe that in and I get into my lungs, remember this is going to go on into my alveoli sacs, and once I get it into the alveoli, it's only going to have 104 millimeters of mercury, and some of that, as you can see, that it mixes with water. Remember I told you it's going to humidify it and add moisture to it. And so therefore this number is going to change from 59 down to 104. So 159 to 104 because of the fact that I've got water and moisture added to that, and therefore some of that is going to convert that O2 is going to convert to CO2. So it's going to increase and my oxygen level is going to decrease because the oxygen is going to combine with some carbon that's there, and I'm going to get some CO2. Okay, now, so adding warming there and adding moisture to it will change the concentration or the partial pressures because it's going to pull some of those oxygens out. Now, once I go from the alveoli and it goes from the alveoli and converts over into my bloodstream, I'm also going to see that drop down. And you'll see this number written, it says 95 millimeters of mercury here. You'll see that written anywhere from 95 to 105. There'll be a variable there depending upon the oxygen content that's in there, how much moisture and so forth is with it. So don't be alarmed when you see this number vary some, but it won't vary much out of that range of 95 to 105 in that range. Carbon dioxide stays pretty consistent through there at 40. And once the oxygen content is in there, it'll be consistent, okay? Then we notice when we get down to the tissue level, and this is important because we're going to be re-emphasizing this and going back to these numbers consistently. So you need to know these numbers, especially what's in my oxygenated blood, what's in my tissue, and what's in my deoxygenated blood, because those numbers don't change, okay? And that is what drives the diffusion to occur. So you got to understand those numbers. So if I look at the numbers of the content in my oxygenated blood, it's going to be oxygen is going to 95 to 105, and my CO2 is going to be 40. Well, when I get to my tissues, notice that my oxygen in my tissue, once it's been utilized, it's down to 40 millimeters of mercury, and the oxygen in my, or carbon dioxide in my tissue is 46. Okay, you see those differences there. So if I'm coming in with roughly 100 in oxygen, I'm coming to an environment of 40, where will the oxygen go? Gases will always balance themselves. They will always go to a point of high concentration, low concentration to become equivalent, to become equal. So if I've got a high concentration of gas on one side and a low concentration in the other, then simply out of diffusion and concentration gradients, it is going to move. So oxygen is going to move out of the blood and into the tissue. So it's going to move out of the blood and into the tissue. Whereas when I look at my CO2, when I come with CO2 down here, it's going to be 40 in my blood and it's 46 in my tissue. So it's going to go from high to low. So it's going to go out of the tissue and into the blood. Oxygen is going to go out of the blood into the tissue. CO2 will go out of the tissue and into the blood. That's how you get the exchange. And once it does that, like I say, it's going to bring back to a point of equalization. So if I do that, then I'm going to have this amount in my venous blood. I'm going to have the same amount I would have had in my tissue. And the difference within those from my oxygenated side will be in my tissue. Okay, so I'm going to gain roughly 60 millimeters of mercury in the tissue, and then I'm going to lose 6 millimeters of carbon dioxide out of the tissue as a difference. And then as it's utilized in exchange, it works it back down to those numbers, and then it exchanges again. But concentration gradient is what's driving those. So now then, with that exchange, then my deoxygenated blood on this side will have the concentration of partial pressure of oxygen. It's going to be 40 millimeters of mercury, and my partial pressure of CO2 will be 46. So then if I carry those numbers then back up to my lungs where I would see that I would have then my PO2 104 and my CO2 of 40, then oxygen is going to go into the blood and CO2 is going to go out of the blood of the alveoli and it's going to be breathed out. So CO2 then is going to go out and oxygen is going to go in. Okay? That's how that whole system works. And just remember the numbers. You got to learn the numbers. It's going to be roughly 140. It's going to come down to the point of the tissues. It's 40 and 46. There's going to be an exchange there, which is going to make the venous blood 40 and 46. When I get back to the lungs, because I've got 104 versus 40 there, that's what's going to drive that constant exchange that occurs all the time, are those numbers. Okay, we looked at the main functions of the pulmonary circulation, but there's also secondary function it has. For example, infiltration. Let's say if we get some air embolism when you're inserting an IV or injecting something IV, and you can get an air embolism. And pregnant women oftentimes will get air embolisms or amniotic embolisms. You can get thrombi, blood clots are there. You can get small blockages from the lungs from the heart, brain, or the kidney. So you have to understand it acts like a filtration process, because remember the pulmonary artery that we have there. The pulmonary artery is going to be to a point that it is going to branch down into 500 million little capillary beds. So that 1-inch pulmonary artery that's coming out of the heart that goes over and it starts branching, getting smaller and smaller and smaller, then that acts like a filtering system to catch any emboli, thrombi, or any kind of small blockages. We also realize that it is in metabolism. For example, remember the chart we did when we looked at the kidney and the fact that we had angiotensinogen, renin converting to angiotensin 1. Well, to get from angiotensin 1 to the active angiotensin 2, it has to go through the process of being stimulated by the enzyme, angiotensin converting enzyme, ACE, and that is produced in the lung. So it plays that role. And then don't forget bradykinin, the prostaglandins, all these are inflammatory responses, the serotonin. The bradykinin and prostaglandins are inflammatory response issues, and activation of those is done in the lungs and breaking those down in metabolism there. The other big thing that it plays a role in is a blood reservoir. These three things that you have here are very important, so I would probably be sure that I know those well in the fact that those will play a major role. Although they're secondary functions, they're major functions that come into play. When we look at the blood vessels that branch along the airways, we have to realize that we have to think about this in the lung field almost backwards, because we're looking at the pulmonary arteriole when it comes in, our pulmonary arteriole that's coming in here that we see. It's going to be deoxygenated blood. Even though it's an arteriole, it's deoxygenated blood, remember. And then it's going to the alveoli. Each of these are going to form this capillary bed around that, around this alveolus that's there. And then it is going to pick up oxygen. And then our pulmonary vein then, or venule here, is going to be oxygenated blood. And that is very important because this is deoxygenated blood on this side, but it's pulmonary artery. So we have to kind of think backwards in that regard in the way that's flowing. So that's the purpose. So each of these capillary beds are going to go around there. I want to go ahead and mention one other thing here because this is in our respiratory or pulmonary circulation. Pulmonary circulation. We also have another circulation that's in the lungs that is bronchial circulation. And bronchial circulation is going to be blood that's going to come off of, for example, our aorta would be coming up like so, and we'd have our branches off of the aorta, which would be my brachiocephalic, left common carotid, and left subclavian as it branches off of this aorta that's here. But also off of that, I'll have these little branches that come off, that come around. That's going to be from a third posterior intercostal that's going to come around. And then I'll have a branch off of the aorta directly on the left side that comes around. And that is what supplies the blood supply to all this parenchyma in the lungs here, okay? Because it's tissue as well, so therefore it has to have oxygen. It's not going to get its oxygen from my pulmonary artery or pulmonary veins as it comes out. The tissue itself, the lung parenchyma, has to have a blood supply to it, just like the liver, kidney, or any other tissue. It has to have an oxygenated blood supply, and it does not come from the pulmonary venule. It comes from what is known as the bronchial circulation. The bronchial circulation, you have the pulmonary circulation, that's going to be oxygen or deoxygenated blood going to get oxygen from the lung. That's its whole function, is to go pick up oxygen from the lungs to carry it to the body. The parenchyma, the tissue, the lung tissue itself, is just like any other organ. It has to have oxygenated blood supply. And it does, and it comes from the bronchial circulation. And that bronchial circulation branches off, like I say, basically off the aorta and third posterior branch of the intercostals that supply the parenchyma tissue in itself. Now, you'll see that that's going to become important a little later on because after it supplies, let's say if it branches off and it comes along here and it's supplying the tissue to the bronchus, to these muscles, and all to the parenchyma of the tissue out here that's laying in between this space that's here. When it supplies blood to it, then it picks up carbon dioxide just like it does any other tissue, and then it's going to come and dump directly back into that. So what's going to happen is I'm going to have some deoxygenated blood that's going to be dumping directly into my pulmonary veins, which is oxygenated blood. That is one reason in which you will see that you don't get like with pulse oximetry, for example, you're not going to get 100% of saturation because you're going to have some deoxygenated blood that's going to be dumped back in there. Okay, so you'll see that be the case. Plus, you're going to have the situation where you see oxygen go down when it's coming out of the alveoli. Remember, I started with 116 in atmospheric oxygen, and then it went down to like 105 or so, and then when it goes into the blood, it's down to like 100. Well, that's why I lose some of that, is because I've got carbon dioxide or deoxygenated blood being dumped directly in there. We're going to explain this a little more in a different drawing later on, but I want to lay that groundwork out there now. You have two types of circulation. You have pulmonary circulation and bronchial circulation. Pulmonary circulation is going, which is what we're talking about primarily, and it is going just to get oxygen into the blood, into the tissues. Bronchial circulation is going to come off to supply the tissue, the parenchyma, the organ of the lung itself, with oxygen. Okay, when we talk about the pulmonary hemodynamics of situations, what we're talking about is we have to realize we have pressure variances or differences that occur from my systemic circulation versus that of my veins. If you'll remember, Our blood pressures that we're looking at from our arterial side, when we look at the blood pressure, when you measure a person's blood pressure, you're measuring the arterial side. And we're looking at 120/80. In other words, in systole, when the heart is pumping, the pressure coming out of the left ventricle, going up the aorta that's going to my body, is going to, at full systole, is going to be 120. And when the heart goes into diastole and relaxation, it's going to be 80. So it's 120/80. That's what normal blood pressure is. And so that's what we're interested in, is how well is it perfusing the body. The venous side, however, is low pressure. Don't have a lot of pressure within it. And so when I'm looking at my venous side, as we talked about, really going back into that left atrium, we're setting at 0 to 8. I'm going to have a little more pressure than that coming out of my pulmonary artery, because the right ventricle, and everyone remembers all their pressures, I'm sure, coming out of that right ventricle is roughly 24. And when it goes up the pulmonary artery, that pulmonary artery is about 1 inch in diameter. And so the pressure is going to be a standard of about 15 to 18. Most material you read shows it at about 15. And so that's what you'll see here on this side, is we've listed it is at 15. And then it's going to dissipate when it gets into, remember, all of these branches that occur there. What they're going to do, you're going to branch into so many different branches, it's going to decrease the flow, right? And so if I decrease the flow by going out into all these branches, I decrease resistance, I'm going to decrease my pressure. So really, when we get out into the capillary sides, we're looking at roughly about 10 that we'll see there. When we get on to the arterial side, our average mean arterial pressure is about 93. So if we're looking at an average of these pressures, not just full systole and full diastole like we are in blood pressure, but if we just say what's the average mean arterial pressure that's there, we're looking at roughly 93 when it comes to the arterial side. And we're looking at roughly about 15 to 18 when we're looking at it from the pulmonary artery. And you can measure that, and y'all learn there's a thing called a Swan's-Ganz catheter that you're going to put into the right atrium. You go into the right ventricle and you blow up a cuff on it or a balloon, and then when the right ventricle beats, it blows it up into the pulmonary artery, and then you can measure that pressure there. You can measure if it's pulmonary hypertension, but you'll be measuring that pressure, especially a thing that you can do under anesthesia, so that you can constantly monitor that and know exactly where you are and what those pressures are. Because those pressures become significant in being able to oxygenate the person well. If I don't have enough pressure that I'm pushing enough blood into those lungs, then I'm not going to oxygenate well. So that becomes significant. But you have to realize that the left side, when we're talking about all of this from the perspective of this whole left side, is all low pressure. Okay, so this is all low pressure, and then our other side, right side, our left side then is all high pressure. So the heart works virtually the same way. You got a high pressure side, low pressure side. The right side of the heart is going to be your low pressure side. The left side of the heart is the high pressure side. And so we have the same thing going on within the lung field. And that becomes important because you got it's low resistance, and so therefore we got low pressure. And realize we're only going from the left ventricle to the lungs. It's not a very long trip. Don't need a lot of pressure to get there, and so it doesn't take a lot. Whereas on the left side of the heart, I'm going to all of the body and all the organs, and so it requires a lot of pressure to do that. All right, so that's the difference within those pressures, and as to why. Another concept that's really important to understand in pulmonary resistance. It decreases with increased cardiac output. Now, you would think the opposite would occur, but the reason it does that is you have to understand that in our lungs, we're only using about 30% of our lungs. So if I have an increase in cardiac output, I have to be able to utilize the rest of that increase of flow that's there to oxygenate, because my body has demands. For example, if I'm exercising, then I'm going to have more oxygen demands on the tissues in which my metabolism is increased. So I've got to have more blood to get to them to oxygenate them well. Well, how do I do that within my lungs? Just because they're not operating at full capacity, only about 30%. But you have also a unique structuring that God has put in place within the lungs that makes it different. So because of this, the pulmonary resistance decreases with increased cardiac output. And the way it does that, if you'll go down and look at this bottom portion of this, you'll see the way what we've got drawn here is in normal. You have a thing that is called recruitment. And what we see with recruitment is that if you look at it, you have these vessels that are just laying there done. Like I say, you only use about 30% of it, so you've got all these extra vessels here that are laying literally dormant. But then as I increase cardiac output here, if I increase my cardiac output, the way I decrease resistance is the fact that these vessels then are recruited so that they will dilate. And if they dilate and start carrying more blood, now I've increased the amount of blood flow that can go through there. And so therefore I decrease resistance. If I increase cardiac output more, I have a process that's known as distension, so that what's happening with these is they are distending, they're getting wider, so they can distend because, again, they're very compliant. And by doing that, all this distension that takes place allows even less resistance, so I can maintain a low resistance or decrease resistance, really. And you got to think about it. This is the opposite of what we talked about with autoregulation in the kidney, because when that would happen with them, of course, it would decrease the cardiac output that was there. And that was what was necessary for the kidney to help regulate our blood pressure to some degree. Well, it's the opposite of that when it comes to the lungs, because they will distend. It's because of this recruitment that you'll see, recruitment and distension, that enables that to take place. And the purpose and intent of all of that is so that you can increase flow at a low velocity, and it allows great gas exchange. Because remember, that blood's going to be moving across at a certain speed and has to have a gaseous exchange. So in other words, for me to be able to get more gaseous exchange to occur, at that flow that's there, I have to be able to maintain a speed within that allows the exchange to take place and not increase velocity. So if I have more vessels than that's dilated, I can maintain the slow velocity, but yet still get great exposure to alveoli to increase gaseous exchange, okay? It increases those areas of the capillaries which are available for gaseous exchange. Because remember, I've only got 30%, so now I'm using more capacity. I'm using more of the alveoli that are there. I'm oxygenating more because of more of the vessels that are there, so that I've got this reservoir, this reserve capacity that I have. And yet I can still maintain these low pressures. And that's important, because if you get high pressures to occur, which does in some cases, that pressure increase is going to cause edema to occur, because there's the pressure it's in that lymphatic duct. If it exceeds the amount of pressure that's in that duct, the fluid then can't escape, and also the pressure can get so great it'll collapse the lymphatic duct. Guess where that fluid is going to accumulate then? It's going to accumulate in the interstitial space, which then is going to pump back into the alveoli, and the next thing you know, now I've got pulmonary edema. So that becomes real important. So those low pressures become significant, as we're going to talk about this in more depth in a moment, in preventing pulmonary edema. Now, there is a concept that occurs that when we're talking about resistance, as we did the previous slide, is pulmonary resistance will increase to some extent regardless. But when we're looking at the pulmonary circulation, we have to realize that the pulmonary resistance increases. Now we're talking about with the alveolus itself. So we're talking about what impact does the alveolus have within my pulmonary circulation when it comes to resistance. And this is a concept, so you need to pay attention. It's a concept that confuses most people in the fact that how does this work? Because the statement is made that pulmonary resistance increases at high and low lung volumes. How can it increase with both of those when they're right the opposite? Well, it does it by two different ways. Because if you think about it from a high volume standpoint here, if we look at it from a high volume standpoint, then if we look at it from a high volume, then our pleural pressure is more negative. The pleural pressure is more negative. So it's pulling that out. So it's pulling air in, right? Okay, that's at high lung volume, means that the pleural pressure, which is, remember, that's my pressure that's sitting outside here, my pleural pressure. This would be my ribs out here, okay, my pleural cavity here, and then this would be my visceral pleural. So this is my parietal pleural, this is my visceral pleural, and this would be my pleural cavity in here, right? And so my pleural pressures would be more negative, so it's pulling out, it's sucking this out, and when it does, it pulls that out, it expands the alveoli, which pushes air in. And as it gets bigger, then it puts pressure on my alveolar vessels that are under it. So by putting pressure on them, I restrict them, because remember, they're very compliant, so I can constrict those. And so what I'm going to do is I'm going to increase resistance when I do that. That makes sense, right? So that's how I increase resistance there. Well, if I'm in a situation where I have got low lung volume, here, like in this case, low lung volume, what happens with that situation is that you still have it's more positive out here in this pleural space. It's more positive here, but it's still negative pressure relative to atmosphere, okay? And so what happens is that, like, let's say if you're talking about with an exhaling situation where you're pushing against it. So now then, as I push pressure to collapse this alveoli, I'm putting pressure in here to collapse this alveoli, to force air out, in essence, and it's at low volume within this, then if I'm putting pressure on this alveoli, in essence, to put it against that, it's also going to apply pressure on my extra alveolar vessels outside of that. And what I'm going to do there is then I'm going to collapse on those, and they're not going to be as expendable there. So it tends to collapse on those. And so it increases resistance. So that's the way that works. You have to think about it. If you think about it in long lines of, if this were inspiration and this was expiration, then I think it'd make more sense to you. But I'm putting pressure on I'm increasing the pulmonary resistance at higher low volumes when we're talking about just the alveoli itself, okay? So if what we just talked about was true, that during inspiration and expiration, at those points of time, I'm increasing resistance, whether I've got large volume of alveoli with inspiration or I've got small volume of alveoli with expiration, at those points, I'm increasing pressure. So that makes sense then that the lowest resistance that I would have, because I'm creating resistance, and both of those, I'm increasing resistance with inspiration and expiration. So my least resistance that I would have, the lowest resistance point, is going to be during my functional residual capacity. If you go back to your chart that I looked at in the last lecture and had those points, you can see your functional residual capacity. What that is, that's when it's at rest, really. That's when it's at rest. It's after you've had passive expiration. No forceful expiration. You're just sitting here and you're just normally breathing, and after you've expired. So that means that that's the volume that's left in my normal lungs at rest. So I'm not pushing or I'm not pulling, and so therefore I've got the least resistance. I got the least compression of my blood vessels at that point, either due to a distended alveoli. It's not very distended, it's just an equal amount, so I don't have a lot of pressure there, and I don't have a lot of force being pushed to push air out on expiration. So that's going to be the point that it stays. Why is that important? Because you can utilize drugs that will alter that, so you can change that resistance depending upon whether you use vasoconstrictors or vasodilators. Big thing is if you're looking for the least resistant point, it's going to be at my functional residual capacity. In other words, when the person is just at rest. In other words, if they're doing just after they've gotten through with passive expiration. That's when the least resistance is there. Another concept, and really that's what we're building on right now, these things I'm laying out for you, different respiratory concepts of pulmonary circulation. Another concept that you have to understand is the fact that when you have low oxygen tension in alveoli, so I don't have a lot of oxygen in there, I've got a hypoxia in essence. I don't have a lot of oxygen in that alveoli. God does this really unique thing within this is he causes the situation such that if I don't have a lot of oxygen in there, then I'm going to constrict those vessels going to it. I'm going to send that blood over to another alveoli that does have oxygen in it, because my total intent and purpose in respiration is to oxygenate the blood. So if I don't have a lot of oxygen in an alveoli, I will get vasoconstriction. You will get pulmonary vasoconstriction. Okay? So this is important. If you have low oxygen content, it causes or induces pulmonary vasoconstriction. So now think logically with me. Why in the world would it do that? It's just the same thing I just mentioned to you. God designed it that way so that I can shunt that blood over to me an alveoli that does have a lot of oxygen in it, so that I can oxygenate the blood. It's an efficiency thing. It just becomes more efficient because you've done that. And so it's the purpose of it is to again, efficiency is to maintain ventilation and perfusion balance. It's so that I can get that oxygen out to the tissues. That's the whole purpose of it. Okay, now we're going to look at fluid exchange within pulmonary capillaries. And this is an important concept because understanding this helps you understand pulmonary edema. And you kind of got to go back to like we looked at in the kidney. Remember in the glomerulus and in the Bowman's capsule and in those areas that we had there, we had hydrostatic pressure in there, and we had a certain amount of basal membrane pressure and so forth. We had these different things that were pulling or pushing in different directions, okay? And so that's important within this concept. And I think this drawing kind of helps you understand it a little better than the next slide. I'm going to need to explain some things here so you can understand it better. But you have to understand that we have to get a balance of pressures. What are all of the pressures that are pushing in? And then we take the sum of all the pressures that are pushing out, and we'll get a net pressure, just like we did with that of filtration within the kidney and the glomerulus. So it's the same kind of thing. Well, what are all the pressures that I've got working for me and against me? Well, I have to realize that I have a low hydrostatic pressure in the capillaries, okay? So in my capillary bed, I've got these pressures that are here, and this is a hydrostatic pressure, and realize that it's going to be pushing out, okay? And then I have this thing that we call as colloidal osmotic pressures. And you'll have some of those in and you'll have some of those out, okay? But these colloidal pressures that are inside of this, in other words, what are the colloids or the different things, the albumins, those proteins that are in there, and they have a tendency to draw, right? They're going to be pulling things to it. And so you have to realize that with hydrostatic pressure, I'm pushing things out, and with colloidal pressure, I'm sucking things in essence, I'm pulling things to me. So I got a pushing and pull thing going on here. Well, I have the same thing happening in the alveolus. I have surface tension that's in there that's going to be tending to pull fluids in, and then I'm going to have air pressure that's in here that's going to be tending to push things out. Then I have interstitial fluid in here that's going to be tending to, depending on what's in there, doing a little of both. And then you've got lymph drainage that comes into play here. And of course, the lymph ducts that are in there are going to have a certain amount of play. So I've got all of these things that are going on. Well, how does that come into play? All right, well, let's look at the next slide. On this, remember that you have your colloidals are going to be pulls, and my hydrostatic pressures are going to be pushes, okay? That's the important thing. And when you get to this point where we have a high P here, it's still a push, but it's to a push to a negative degree, but it's still a push, okay? It's virtually suction in essence, but it's still a push when you see the negative that's there. Okay, when we look at this, this is going to be a little confusing in the way that they calculate this out, so don't get too caught up within this, but the thing that you must remember or you need to remember is the end result of this, and that in essence is this, is that the net filtration pressure is about a +1 millimeter of mercury. Well, how did I get to a +1 within this? Well, you have to think backwards a little bit here, because realizing that anytime I'm talking about my pressures again, where I'm talking about my hydrostatic pressures, they're always pushing. So this is a hydrostatic pressure of blood, so it's going to be pushing in this direction, okay? This is a hydrostatic pressure of the interstitial space that's there, that's in there. It's going to be pushing this way, but it's going to be doing it at a -8. Okay, so it's really sucking it, but it's actually intensely going that direction because it is a pressure. These are colloidals, and colloidals are going to tend to draw, right? They're going to pull. So my colloidals, this pulling things in this direction, and this is pulling things in this direction because it is a pull, whereas my other pressures, go back to the slides where we're talking about, when we're talking hydrostatic pressures, they're a push, or you're pushing to a point that you're creating suction as you are with a negative. And then my other pressures that I have within this are going to be a pull because they're colloidal pressures, so they're a pull. So then if I add up all of the numbers that are going in the same directions, I would have this 7 here plus this 14 going in that direction, minus my other pressures going in the opposite direction. In this one, I've got a push in this direction of a -8. So it's -8, and a pull in this direction of a +28. And so that would give me 21 minus 20, which is equal to +1. So that is what is important. Okay, so when I take all of my pressures, the pushes and the pull, even though one of my pushes is a -8, it gives me what is my standard. So I am going to have a tendency of the pressure going in this direction of a point or +1 milligram. So what it's trying to tell you, all of this, whether you're good in math or not, realize this principle. That's more positive flow from the blood into the interstitial space, into the alveoli, than it is back into the blood. So it's going to go out of the blood into, so where's fluid going to go? Where's water going to go? Because the net pressures are a +1 in the interstitial space, fluid will have a tendency to go in that direction, okay? That's important because the fluid that goes in there at that point, that fluid can seep out and go in there, picked up in the lymphatics, and is carried away. Okay? That's standard what happens. So the fluid does not build up and accumulate within the bloodstream, but it's going to accumulate within interstitial space. Some of it will seep in there, in other words. Not all of it, not a large volume, because I'm only at +1 millimeters of mercury. That's a very small pressure, so I'm going to have very little of it's going to leak in there. Okay? So now, why is all that important? Well, as I told you, don't worry so much about how you got there. Just remember that you got there and that I'm going to have a positive pressure of fluid that is going to tend to go and leak to the inside of this because it's a +1 millimeters of mercury. And so why is that important? Because it's going to have a tendency to pull any excess fluid I would have in my alveoli, not necessarily just out of your circulation, but also in my alveoli, is going to flow in this direction. So the fluid's going to come out of my alveoli, which is good because now I don't have it accumulating fluid in there, and oxygen and gases can occupy all of that space and not fluid. Where's it going to go? Well, inside my lymphatics here, that's inside this whole interstitial space, the pressure in it is a -5 millimeters of mercury. It's a suction within that. So if my pressure out here is 0.1 or +1 millimeters of mercury and a -5 here, it's going to suck that fluid into my lymphatics and it's going to be drained out. Makes sense? So I can pull all the extra fluids that I would have in my alveoli and in my circulation, the excess fluid that's there will be drawn into my lymphatics. Lymphatics is going to go to the lymphatic ducts. It's going to go to the lymph nodes. It's going to drain back into the venous blood, and it's going to be excreted. Okay, so that's how that's going to work. Now, why is that important? I have to understand this concept, realize when those pressures change, then so will my abilities to drain the fluid. For example, let's look at this next slide. Okay, in this situation, let's say that I've got a circumstances in which my pressure is greater than 5 millimeters of mercury pressure. Well, how could that happen? How could this be greater than 5 millimeters of mercury pressure? Okay, well, let's just see. What if I had a situation where I had left-sided heart failure? If I have left-sided heart failure, the blood's not going to be pumped out of my left ventricle efficiently. It's going to back up into my left atrium. From my left atrium, it's going to back up into my pulmonary veins, which is going to back up into my alveolar capillaries. Okay? And so therefore the pressure keeps building up, keeps building up, keeps building up. So if I get left-sided heart failure, listen to me, that's the reason. If you get left-sided heart failure, you will always get pulmonary edema. Always. And the reason is because these pressures inside of this are going to increase. They're going to go up. And when those pressures go up, then it's going to drive the pressure, hydrostatic pressure now, it's going to increase, and it's going to be greater than 5. Normally this would be 1, right? Our normal pressure in here would be a +1. That's what it would be normally. Okay? It would normally be that. Now, all this pressure is increased, and I'm greater than a +5. Now, I could get it up to 4, and I'm still okay because my pressure in here is still a -5, and I could draw it out of there. But when I get to a point that I'm greater than +5, then that fluid is not going to go in here. It's going to stay in here because the pressure is greater. And so next thing you know, the fluid is going to go in here because it's greater than there. And so now I've got pulmonary edema. Make sense? It's pressure related because of that difference within the pressures. The pressures builds up because my left-sided heart failure, pressure goes back, builds up within that, then that fluid pressure is greater on the outside of the interstitial space than it is in the lymphatics, which is -5, and then that fluid is going to go into the alveoli, and now I've got pulmonary edema. You'll also have fluid accumulating in here as well, in this interstitial space that's there because it's not going to drain out of those lymphatics. Okay? That's how you get pulmonary edema. Okay, when we look at causes of pulmonary edema, when we look at those things that can cause it, of course, pulmonary edema, number one thing is going to be left-sided heart failure. Okay, when we look at the causes of that. Damage to the pulmonary membrane, you can get that to occur, and again, you're going to create the same thing. It's just going to be a different effect that's going to be there. What's the safety factors built in so that it doesn't kill you, which eventually it can, especially when we get to a point where we're talking about ARDS, where we get that much more fluid build up, and it's almost like an allergic type response that occurs in some people. Fluid builds up so fast, and you have to increase forced ventilation and increase PEEP, but you still can't do it enough, and 50% of those people die. But safety factors here help you is that you've got negative interstitial pressure, which will help you to some degree keep it out of the alveoli and keep it in interstitial space. And then, of course, you got lymphatic pumping that can help pump it out of there when excessive gets up. But then you have a decreased interstitial osmotic pressure, which will help keep it out of the alveoli. But when you get pulmonary edema, you override all those safety things into a point that it can be more and more serious. And that's why you're going to use things like some of your loop diuretics that we talked about, and it'll dry those lungs out. Okay, we look at ventilation differences within the lung. We're going to look at different areas of the lung. So if you take a person who stands up, and if they stand up, just gravity alone, the lungs are going to have a tendency to move downward just by gravity, right? So it's going to pull down against the diaphragm here, okay? Now, when I do that, I'm going to increase or widen this space that's here. And so if I increase that space that's there, just like when you breathe, your ribs move away, your diaphragm goes down, and you're increasing the space in there, you're increasing the negative pressure, you're increasing the suction that's there, okay? And so you'd have the same thing. That's the reason it goes to a -10 there. And with the lungs moving down here, it closes this space. And so it's a -3 pleural pressure. But it's not the pressures or the suctions that's going to come into play here as to where the air is going to flow. It's because of the impact on compliance, and that's the issue. All right? It's not the negative pressure or suction alone that's working here, it's compliance that comes into play. So if my lungs are pulled down in this direction, it tends to stretch or pull taut and tight this part of the lung. Just stretched it down and pulled it down. And when you've got an area, if you took a rubber band and you stretch it all almost as tight as you could, then you can't very well stretch it anymore. So it's not as compliant. But if I take that and I pull the rubber band, part of the rubber band tight here, and it's tight in this area, but it's lax or loose in this area, then I've got a lot of compliance in that area. So then the airflow will go to that compliant area. It's not going to go to the non-compliant area. Okay, the airflow is going to come here. So the air, then it moves in. It's going to freely flow within this area of the lung, the lower part of it, because it's more compliant. The top part of this lung here is non-compliant because it's stretched by gravity. It's pulled down, it's stretched. So I can't distend it much more. I don't care how much suction I put outside of that. I can't increase the amount of air movement that's going to go in there to fill those alveoli. Now, it's not a complete collapse of them. If you did, they'd be atelectic lungs. But I've got more pressure up here, more suction up here, so it's going to have some air movement in it because of the increased suction that's there. But because of the lack of compliance, it's not stretchable, then it's not going to be sustained. So the air movement is going to move, it's going to go to the lower part of the lung, because it is more, the lower part is more compliant than the top part. And that's an important thing there, is compliance comes into play within that regard. Irrelevant what the pressures are, how much suction is there, compliance has to come into play. Because they can how much suction you put on something. If you've already stretched it to its limit, you can put all the suction you want to on it, and you can't distend it. We also have to consider not only the lung in itself as the tissue portion of it affected by gravity. Blood flow is also affected by gravity. Blood's going to pull that flow of that blood downward as well. So not only will I have airflow into the bottom of the lung because it's more compliant, but the blood flow is going to be there at the bottom of the lung as well. So I'm going to get a higher perfusion, and a higher ventilation is going to be in that base of the lung, because I've got more blood flow there and I've got more compliance there. Okay? Should make sense to you. It's just a gravity thing alone. That blood's going to flow downhill. It's going to run downhill. And if I've got a person standing, it's going to run to the bottom of the lung. So I've got airflow is going to go there because it is more compliant. I've got more air there. I've got more blood there. So guess what? I get more perfusion, more ventilation there. With those things explained and understood, you should realize, I won't spend a lot of time on this slide because you should understand these principles then, that the fact that you're really going to have 3 zones to occur. And practically or physiologically, we actually just have 2 zones to occur, because this first zone here, that's just not normally going to occur, in which you would have a situation which are going to be in this zone here, okay, where you would have the alveolar pressure. That's what you see. These are partial pressures. Anytime you see the large A, that's alveoli. Small a is artery, and then of course that's going to be vein. All right, that you would see there. So you wouldn't have a situation where the pressure in the alveoli is greater than that of the arterial or the venous pressure. You'd collapse it all off and close it, and you wouldn't have anything going on, unless you had some pathological conditions which could occur. But in zone 2, you will have those areas, and that's going to be in those zone 2s that you see here. You will have the partial pressure of the arterial blood is going to be greater than that of the alveoli, which is going to be greater than that of the vein. And then when we get into zone 3 area here, you're going to have that situation which the partial pressure of the arterial is greater than that of the venous, which is greater than that of the alveoli. Okay, because airflow is going to go into there, you're going to have more blood supply there, so therefore you get a situation where the alveolar pressure is lower than the venous pressure, then the blood flow is not determined by the alveolar pressure. Okay, which is what that's stating in is 3. Okay, so just look through those things, and you should be able to figure out those bases of those determinations. But those zones become important to you because if your patients are laying down or standing up, now I'm going to have an impact upon where this is going to be ventilated better and where I'm going to get better perfusion. Okay, now gravity is going to cause a mismatch of ventilation and perfusion. And if you remember, this is written, we'll have to realize that this is something that we're going to look at from now on, this thing that is called the this is called the VQ ratio. And normally we look for that to be roughly 1 to 1. Okay, that's about what we're looking at, is a 1-to-1 ratio. Really, it runs about 0.9 to 1, but 1 to 1 is roughly the standard. That's what you're looking at for a normal VQ ratio. Okay, and so if we look at in the situation that we're talking about earlier, where we said the base of the lung, both ventilation and perfusion are higher at the base of the lung. Then when we look at that, we're really what we're considering there, it's about a 1-to-1 ratio. And so what we're shooting for in a normal VQ ratio, like I say, is about 1-to-1. But when you see gravity along come into play there, it's going to be different in the apex than it is the base. For example, in the base, you're going to have a greater perfusion of blood there than you have in air, whereas at the apex of it, remember, because of the stretching and less compliance, you've got air in there, but you don't have a lot of blood flow because the gravity is going to carry the blood flow down. And even though you don't have as much air as you would normally because it's less compliant, you still have virtually more air than you do blood there. So that's what it's talking about. You're going to have in these zones, you'll have varying in VQ ratio if you looked at it per zone. Normally, we look at it as the whole state of the lung, though, where we are within a VQ ratio. That will become more important, especially when we talk about in pathologies, because pathologies impact that VQ ratio. So if I have something that constricts the bronchiole, or that would impact the amount of air it's getting, so I'm impacting ventilation. But if I have something that constricts or blocks my capillaries, then I would have an impact in the perfusion. So that's the reason we measure those in VQ ratio. And what we're looking for is the ventilation and perfusion. Q is perfusion and V is ventilation. Okay, with that in mind then, let's look at some abnormal ventilation perfusion ratios. If we understand what we talked about earlier, we'll have these variances in the lungs from those zones, but overall is what we generally look at it, and realize that when we're talking about a VQ ratio, we generally realize ventilation is what we drive this off of. So the ventilation is what we look at first in VQ. So if we say that we have in a normal situation here, in this normal, we'd be looking at it, and we would have our partial pressure of oxygen is 102, partial pressure of CO2 is 140 that we would have, that would be going from our bronchioles. And then our perfusion that would have in our venous side coming in is 40 millimeters of mercury of oxygen and 46 that of our CO2. We realize that that's what we would normally have. Now, if I have what is called a low VQ ratio, and again, when it says low, it's generally the high or low is referred to the ventilation side of this is the way I look at it. It's a simple thing. So if I see it's low, it means I've got low ventilation. If I have a low VQ ratio, my ventilation is low. If I have a high VQ ratio, ventilation is normal or high, but my perfusion is low. Okay, so that's what that's stating there. So if I look at these things from that regard, if I have a low VQ ratio, then that means I have to have something that is impacting my ventilation and not allowing ventilation to get in, which would be something that would occur like where I have a constricted or obstructed portion of either my alveolar duct, my terminal bronchioles, or respiratory bronchioles, and down in those stages of it, such as I would see when I would have things like, say, COPD, chronic bronchitis, asthma, emphysema, those things. I'm going to get some constriction here so that air flow is impacted. So my ventilation would be impacted with that, okay? And so then I can get in, especially asthma and chronic bronchitis. Constricts that so the airflow doesn't get in. If you'll notice, my perfusion is still good. My perfusion is normal. I don't have any impact in that. So my perfusion is okay, but I have a restricted amount of air that's getting in here or getting out, and so I have a low VQ. My ventilation is low. Whereas if I'm looking at a high VQ here, with that I would have constricted on my vessel side so that I've got, say, pulmonary embolism here. So block that off. I don't have as much blood flow to get in here. My ventilation is fine. Ventilation is going in here, it's fine, but my perfusion is poor, so then I would have a high VQ ratio, okay? And so hopefully that'll make sense to you when you look at those things, okay? So that the important part is the VQ ratio. You'll understand that, especially when we get into pathology, that comes into play. But it's also important for you when you look at anesthesia, because if your VQ ratio is impacted, then you know that you've got a low VQ, then I'm not getting enough oxygen in to oxygenate the blood. If I've got a high VQ ratio, I'm not getting enough blood in there to be able to oxygenate it.